Hello. Hello, Dr. Sarkar.
Hello, Dr. Swati.
Can you hear me?
Good morning. Yeah, good morning.
Yeah, hi.
Hi.
We're just about to start, Dr. Swati.
Hi, hello, good morning to everyone.
Good morning. This is Brigadier Sana.
Hello, sir.
Good morning, Dr. Swati. Palani.
Good morning, sir.
Pratik sir, I think we are live and we can start.
Right, so I was just waiting for the 15-second cue. A very good morning, ladies and gentlemen, wherever you are. My name is Pratik Kumar. I'm the country director of Malaria No More India. It gives me great pleasure to host this very important webinar where we have a range of speakers speaking about something that is really, really important when it comes to malaria elimination. Most of us working in the field are aware of the Prime Minister's clarion call way back in 2015, where he gave us a date that by 2030, the country should be malaria free. Now, in order to do that, the country has to reach 0 cases by 2027 and stay that way for 3 years for the WHO to certify us malaria free. The country today has made great strides in malaria reduction, but the elimination battle is going to be very different. And we have various states and various partners, including municipalities, public sector undertakings, defense, private sector, and several other players who have not necessarily joined forces in the elimination battle the way it should be. Elimination means eliminating the very last foci wherever it is detected. And that means a very intense, a very hands-on, a very real-time program. That is what has been followed in countries as big as China, who have managed to eliminate it. India will have to do something similar. We are currently also in the next phase of what is called the National Strategic Plan. This is a 5-year plan, the first of which started in 2017 and ended in 2022, is about to end. And we are about to embark on the 23 to 27 plan. And that is where I feel that a whole range of stakeholders need to now join hands. We also need to think differently. We must be looking at new innovations and new techniques, use data, use technology to really make the end game for malaria possible. Now, to discuss this and more, we have a very illustrious panel that you're about to meet. It is my pleasure to now invite Dr. Kaushik Sarkar, a colleague of mine, who will now be moderating the session. Over to you, Kaushik, to take us through the proceedings.
Thank you so much, sir. And good morning, everyone. My name is Dr. Kaushik Sarkar. I'm the Director of Institute for Malaria and Climate Solutions at Malaria No More. It's very nice to have a rich audience today. And I have a challenging task to take forward because I have, I think, several doctors on the panel and also persons from the science communication side, persons from the army background, and this is a very diverse panel to manage. And so I will take the easy task first. I have with me Dr. Rajiv Tandon. Dr. Rajiv is a highly experienced health expert in India. He is the Director Health in RTI International India, with a demonstrated history of working in the public health and nutrition sector as a thought leader for about 4 decades. And with his rich background and experience, I'd like to start with the health systems perspective in malaria elimination. So we are fighting with malaria for the time immemorial, and since independence, malaria was one of the first programs in India, or public health programs in India, that started, and since then it has been continuing. We have seen a lots of ups and downs. Our previous generation was very close to eradicating malaria at one point, but we failed, and now we are again on the verge of eliminating this particular disease. So we believe that this is an experienced program. But having said that, this program has actually notionally seen majority of the health systems challenges and issues. So when we are very near to the end game, when we are approaching to it and planning to actually make India malaria free in the next 5 years, so I will request Dr. Tandon to talk a little bit that what should be our priorities from the health systems point of view to end malaria in the next 5 years. Sir, if you are listening, over to you.
Yeah, thank you, Dr. Kaushik, and thanks to all the other panelists who are with us today. And thanks to Malaria No More for organizing this very important webinar. As Dr. Kaushik has asked, he'd like me to talk a little about the health systems. Very broadly, when we are focusing on health systems, what we are trying to address is how can health actually reach every individual in India. Very broadly, the health systems are divided into the public sector health systems, which is what Government of India actually puts in place, and the private sector, which private institutions, corporates, corporation hospitals, private hospitals, and so on and so forth put in place. Between these two, it's also important just to flag that there is a group of medical colleges which also provide healthcare. We have a very eminent person from the armed forces. So the armed forces provides healthcare. There are institutions like ESI, CGHS, which are quasi-government, which also provide healthcare. Another thing I'd like to flag is that when I talked of the public sector and the private sector, I tried to mention that part of private sector, which is usually called the organized private sector. But in India, even till today, in spite of everything that has happened, there is a fairly intense, large, spread out, informal private sector, which is traditional care providers. We could call them quacks, we could call them RMPs, we could call them Bengali doctors, we could call them Chola Chap doctors. And why I'm trying to highlight that is that there is reason to believe that something like 60 to 70% of first point of care provision is provided by them. So broadly, you have the formal private sector, the informal private sector. Both of them are where there is a relationship of patient has to pay for the facilities he or she receives. And on the other side, there is the public health system. I'll go a little more deeper into the public health system, which is possibly more relevant for, like Prateekji mentioned, malaria control and malaria elimination, and we have a target and so on and so forth. Because that is where, number one, nobody pays for all the services that they receive. Number two, that the design of the public health system is mandated to reach everybody in India. So whether you are in an urban area, whether you are within an urban slum, whether you are in a rural area, whether you are in an insurgent area, whether you are in a tribal area, the public health sector will reach you. How would it reach you? You have what are called the frontline multi-purpose health workers. You could call them ASHAs. You can call them ANMs, auxiliary nurse midwives. Above them, you have the nurses and the doctors. The platforms from whom these entire army of healthcare providers work are, of course, the last point is engaging in the community. So what all happens in the community? And when we are talking of community, we are really mandating what is called ASHA, the accredited social health activist. Broadly, the activities that happen in community are enumeration of the population. So actually to know what is the size of the population, all the outreach activities. So whatever needs to actually be reached to people, the outreach activities, all the screening that has to happen in the community. So what is called community-based screening, the risk assessment. So that's the first point where a person's risk is assessed for diseases, for disabilities, for whatever. All the awareness that has to be generated by them. All follow-up actions in health and wellness has to be done by them, and the counseling on anything and everything has to be done by them. During COVID, we have also seen some aspects of diagnostics, some aspects of drugs also being actually made available at that level. So that is the last point of the public health care, which actually reaches individuals' houses in villages, in any part of the country, in urban slums, in any part of the country. Above them, so imagine that they have identified somebody with a disease or with some risk or with some needs. Their job is to ensure that that person, if is not taken care of by them themselves, is referred to what is called the subcenter. At the level of the subcenter, you have now in some parts of the country, because of a program called Ayushman Bharat, a community health officer. And you also have a mid-level health provider. Here, what all happens? The first level of healthcare is provided here. Screening, diagnostics, drugs, record keeping, and telehealth especially happens here. Also, if the patient needs something more and above, referred to what are now called the primary healthcare centers, which are at a larger population base. And it's here where you would find the nurses and the doctors. Here you have, again, further diagnostics, treatment, prescriptions are given here. So a doctor will actually see a patient here. Complications are diagnosed, and if the need is there, patients are referred. Real-time monitoring is done here. And again, telehealth is something which is across the board now. Again, if a patient needs still further, more specific care, they are sent to what are called community health centers, sub-district hospitals, and district hospitals. Here, advanced diagnostics, advanced treatment, complications assessment, tertiary care, and the facility of what is called PMJAY. Under Ayushman Bharat, monies are made available through community insurance for actually surgical interventions and so on and so forth. Now coming and trying to answer what Kaushik actually asked. We are in a situation where, number one, the informal private sector providers, what they are doing, nobody seems to know. Number two, the formal private sector providers, how many patients they are treating, who and what is the outcome, the country does not know. The medical colleges, the patients that are being treated, and what is the outcome, some medical colleges, because medical colleges are again a mix of government-owned medical colleges and private-owned medical colleges. So the private-owned medical colleges also, the data is not available. The data that we have today is based on the system that I talked of, which is ASHA, auxiliary nurse midwives, nurses, lab technicians, and doctors. So like Prateek ji mentioned, we have a small window. We are in 2022. By 2027, we should be zero. So you could imagine what all needs to be done. We somehow have to ensure that everybody who is suffering with fever should be investigated for malaria. I am sure all of us on the panel, even if we end up having fever, the first thought that comes to us is viral hua hoga. Somehow our behaviors have reached a point where we do not think that there could be something that is called malaria. So the first point is everybody who has fever should be investigated. Second, every patient who is investigated and then diagnosed to have malaria, the data should somehow reach the people who will influence policy and program. And third, of course, are issues around diagnostics. There are different types of malaria. There are issues of acute and chronic and which type and will they go into recurrence and all. I wouldn't go into that. But very broadly, Kaushik, I don't know whether I've done justice to what you wanted me to say, but that is where we are as far as malaria is concerned, as far as health systems is concerned, as far as a country, India, which is 1.4 billion people today. Thank you.
Thank you so much, sir. And the initial background that you gave in terms of the myriads of different settings in India in the health system and how complex it is. And we always talk about underreporting. We always talk about hidden burden, but it's not essentially underreporting. It is basically one sector is not being included in reporting, whereas some other section or part is being included in the reporting, which is actually creating a bulk of a problem in the understanding of the distribution, size of the magnitude of the problem, and how we deal with that problem around the time of end game. So thank you so much. And sir, I have specific questions for you, but I will come to those questions maybe after taking another panelist, Dr. Swati Maheshwari. And Dr. Swati, you are from the private health sector, and right from the point where I think Dr. Tandon started, Dr. Swati is trained as medical professional with experience of 15 years in the field, including senior roles in delivery of healthcare. She has been consultants with some of the leading hospitals in India, and she has a rich experience in private healthcare delivery. Her research and academic background helped her understand the needs at point of delivery of such services, and a career developed directly from delivering healthcare in a clinical setting to managed healthcare services. So I believe she has the test of both, treating the patient and also seeing the sector very closely. So Dr. Swati, I will come to you with a very quick question before the generic question from the sector perspective. How is a case of malaria generally managed in the private sector? So you are in the private sector, and we are really curious to understand that how often these cases are managed, how it is managed, and how often these cases are notified. Because I'm taking this from Dr. Tandon's reflection that we don't know how many cases are there, what are the outcomes, and what are to be done with them. So over to you before we move to more deeper questions.
Thank you, Dr. Sarkar. First of all, a very good morning to everyone joined here at the webinar and the panelists. And a big thank you to Malaria No More and Economic Times for having me on this panel. I would start with saying that, malaria is a victim of complacency. And since it's an age-old disease, and with the advent of newer rapid diagnostics, accessible ones, and also with the efficacious drugs that are there, there is arguably, I would say, less of urgency around the disease, as we see with most of the recent public health emergencies. Now, if you look through the lens of a private health sector setup, I would like to echo the sentiments of Dr. Tandon over here, because for the private health sector, the goalpost is not elimination of the disease. The goalpost is, limiting the morbidity and the mortality of the disease. That is where the action actually comes into, and it is limited to that as well. Now, when we are going through this COVID times, and what we say now is living with the virus, you need to live with the virus. I think we started living with the parasite as well. And that's the mindset of the people now, that since malaria is so curable, since malaria is no longer a, kind of a health emergency, since, the drugs are there, the diagnostics are there, so we can limit the disease. And I think that is what the end game also started to be recognized as. If you look at the private sector, for them, the end game is to limit the disease and not elimination of the disease as to what the actual end game is. And when we talk about the private health sector, as Sir said, very rightly mentioned, that 70% of the healthcare of India is being delivered by the private healthcare sector. And there is a large chunk of this informal healthcare sector, which is there, which, if you look at it, even at the surveys from the pre-COVID endemic time, I think the surveys very clearly highlight that, there are a lot of hardships for a person to reach the private sector for treatments and all. And for that, around 50% of the people who suffer from fever actually do not land up to a proper healthcare system, be it public or be it private. And there comes the role of this informal sector, which is the first point of care where they reach out. And if you look at it, there is lack of awareness about malaria control, malaria management. And what we see is, incomplete radical treatments, we see relapses, we see reinfection, we see self-dispensing of drugs by chemists, we also see self-treatment for that matter. And all this, I would not leave the formal sector outside, because there is a lack of awareness of national drug policy, not just in the informal sector, in the formal sector as well. And that's why we see a lot of overzealous kind of treatments. We see presumptive diagnosis, we see presumptive treatments, we see utilization of second line drugs as first line drugs. And that's why I think, use of IV artesunate or its derivatives has become very, very rampant even in the private health sector, which actually should not be the case. And also, despite the government banning the monotherapy, still we see a lot of monotherapy being given. And this, I think, is a huge potential and a threat to the entire elimination program, because we are moving towards drug resistance. So if there is lack of awareness about the national drug policy in the formal and the informal sector, then we are slowly jeopardizing, I think, the most effective compounds we have today for control of malaria. And I think that is very, very essential, because nobody knows how to differentiate between severe, complicated, Vivex, falciparum, which drugs to use. I think the first drug everyone kind of reaches out now are to the artesunate drugs, which are actually second line drugs, which should not be reached out to. So chloroquine and the age-old different drugs, and also the radical treatment with primaquine, is not being adhered to. And that is, I think, leading to a lot of problems. Then again, as you very rightly mentioned, coming to notification of diseases is a huge problem, because despite states declaring the disease as a notifiable disease, what Sir said, I would really point out to that there is no data, no data, as to how the private sector is actually dealing with the malaria cases, because there is no notification of such diseases, even in states where the law has been enforced that the disease should be notified. So if you look at diagnostic centers, if you look at various private practitioners, if you look at various private sector, there would only be a handful of, I think, such organizations or people who are kind of reporting back to the government and saying that, yes, we have a malaria in our area, or we, saw a malaria patient. But most of them are not actually doing this, because our main purpose right now is just to modify the mortality and morbidity of the disease and not move towards elimination of disease. And that's why I feel it is the right time, and you very rightly pointed this out, and this is a very opportune time to have such kind of a webinar where you need to include this private sector, which is completely out of the community participation, which is completely out of notifying the disease, completely out of awareness of the national drug policies that we have. So we need to include them, kind of get them included in the entire program and make them understand that there is seriousness of elimination of this disease and not just containing the disease. So we don't have to live with the virus forever, with the parasite forever. We have to actually curtail it down, and we have to eliminate it by 2027. And this sector is going to play a very, very big role, because when we don't notify diseases, there is poor surveillance of mobility populations, tourists, of, I think, transitory urban slum populations that are there, and a very large chunk of unmeasurable, I would say, the parasite reservoir, which is there in people who have no minimal symptoms, which get lost completely. So I think the private sector needs to gear up, and they need to understand, and the government needs to make them understand that they are an equal vertical of elimination and our goal towards 2030, and they need to participate as well.
Thank you so much, Dr. Swati, for comprehensively laying out the issues that are there. I will take two broad points out from there. And that actually reminds me, one of my professors who used to say, I think 2 decades back, India's population are often not health conscious, they're not disease conscious, they're often death conscious. And what happens with that is, you talked about the goalpost right in the beginning of your deliberation, and you talked about survival, and the private health sector is actually catering to that need of the population. So basically, you talked about people's access, their awareness, the awareness regarding policy among providers. You talked about drug, adherences, compliances, notification, surveillance, and all that. With all of that, what comes to my mind is basically the program is unorganized. That means the national program has not reached to the or inclusive of the private sector. When I say organized, probably the most organized sector in India is basically the Indian Army. And from there, we have Brigadier Dr. Sandeep Sinha. Sir, again, thank you so much. We are grateful to have you on this forum. And just to introduce, Dr. Sandeep Sinha is a trained medical professional with a postgraduate in preventive medicine from Mumbai University. He is presently engaged with the Army Medical Corps and in the past has been associated with all 3 defense services for over 3 decades. He has also been heading the med organization of the Indian Coast Guard. Thank you so much, sir. And my question would come to you that with the perspective that what are the, in terms of organizing the care delivery, from with some of my friends in the army, my perception is that it is very organized, it is very, tailored to the situation where army belong, and it is delivered in a very, I would say, niche way. So with that, would you please give us a background that, how the care is being delivered, how the program is being delivered, and what best practices can the civil area, can the civil life of India actually take from there, and we can take some of those best practices to actually curb this challenge that we have in India's, unorganized program in the private sector community and all.
Thank you, Kaushik, for including me in this panel, and very, very grateful to you all. And thanks again, not only me, I'll be representing and talking about the Army and Navy, Air Force, and Indian Coast Guard. Thank you for recognizing the Army setup that we have been doing and organized sector, and how we are doing. I'll be discussing in subjective in coming discussions. I will say that enough lessons have been learned since 1958, right from the brink of the eradication, elimination, and then we started resurging again because of the failures. The first thing which I like to tell this panel is these lessons which are learned in 60s and also the present pandemic of COVID, we have seen and learned many lessons, and India has done well in controlling many diseases. I will agree with one of the panelists who said that we are afraid of death, Indians. We are not the disease. This also comes in the terms of the non-communicable diseases. Coming to Army, I agree with you, Kaushik, that we are little organized, and how we do go about it. First, I will talk about the challenges which we have. The biggest challenge which Army faces is that we are at different terrains. We go to the different terrains, unknown terrains, international terrains, national terrains, and also at peace stations. So we divide the whole thing into 2. Here, the first thing, we as a medical officer, preventive medicine, we have got a organization called as at the unit level, known as Station Health Organization, where everything is controlled as far as the prevention of the disease is concerned. Not only the curative, but the preventive aspect is also given big importance in Indian Army. And as far as I'll talk about the malaria part, malaria, the field challenges, mobility, as I told you before. So military intelligence, health military intelligence to be specific. We have to be very, very particular about that, where we are going, what is the prevalence there, what is the incidences there, what is the season, and accordingly, the mobility of the equipment plus the medications, the medical stores are also mobilized accordingly. Army has got another problem of man-hour losses at field especially. I'll be talking about field first. So there we have to be very, very quick, number one, in prevention. And if something happens, then what? And Army has given a lot of examples in the past, like rolling down of the sleeve has been practiced since ages, where the mosquito bites are prevented. And the boots, of course, it has got multiple reasons of mosquito bites and the snake bites, etc. Basically, we concentrate, as I told you, station health organization, where the data is collected. We also have a problem of imported malaria to the station. People go on leave, they come back with the parasite. So the basic control is parasite. And I used to call it as activated passive surveillance. We have to be very, very particular. And once we get a case, say in the smallest medical officer or a paramedic who sees a case of malaria or fever, he investigates him for the slide. And we concentrate more in the field on the slides only, not PCR. And presumptively treatment is given and radical treatment is of course followed. And station health organization has got every information about the men, their families, their children, everything is maintained. And that is reported to a, say, higher authorities. Then from higher to the highest. And this, what actions are being taken is also included in that particular monitoring and surveillance. Notifiable disease, somebody has already spoken about. I agree. And that is really practiced in Indian Army. We mainly concentrate on the parasite control through the passive surveillance and active surveillance also. And passive surveillance is practiced much more in Indian Army because we have got something called as the doctor should know or his paramedic should know, depending on the size of the unit, that my man is suffering or not. That is the thing. And vector control is most important in field as well as in the peace time, where peace places where the regular 7-day cycle of mosquito is kept in mind and anti-larval measures are continually, they will be there. However, the mosquito flight from the civil area to the army defense personnel is an issue which we try to address. As far as awareness is concerned, I will be proud to say that Indian Army is quite proud of diseases. Not only the hires, but also the individuals. And the community participation we get a lot. I will not say here that we Indians are not health aware. COVID has taught us. We have practiced it. People have done the practices of prevention in the form of, say, vaccines, say, right from development till the user who takes it. So I will somehow say that Indian population has got the acceptance of health issues are to be addressed at right time. We are at the stage where we are looking at 7.5 years now from now, 2030, we zero malaria, and I'm sure we'll do with the kind of political will which is there today, where we could not only control proportionately the deaths were reduced in COVID, but also the basic thing of making the toilets in every part of the country. Coming to monitoring, private sector has been discussed here. we also face this issue of people going to the private sector because of, say, there are various reasons which I'll not be able to spell out, that people go to private sector, leaving the defense sector and go to for medical advisors. Here, I would like to definitely consolidate and reinstate that point, that private sector has to be organized, and every individual, if Government of India can form a policy where every individual who can be like army accountable, a particular station or say PHC or say as said Anganwadi worker, if they can be accountable for each person, that whether fever is there or not. And we have been taught also in preventive medicine that the paramedics plays a major role in prevention of any disease. Something is also called as, somebody discussed about the drug policy. I think that the drug policy already exists, including India and Northeast. I'm sorry, I could not read the whole literature. And the multi-drug resistance and basic drugs in armed forces, I'll definitely say the chloroquine and primaquine works. There is no issue in that. And we also, of course, we are admitting the cases of malaria. Notifiable, it is definitely, as I told you before. And that is the only thing which is practiced. Monitoring, reporting, and the time-to-time conferences. Even we go to the extent of where I like definitely mention the individual's awareness. I'm sure the panel will agree with me. The smallest possible place of breeding of the vector, say cooler water, say the tire. So that is regulation. That comes under regulation as far as army is concerned. So in my opinion, as far as I am concerned, I'll be definitely reinstate again that army works on proper monitoring system, immediate intervention. Any case of malaria found, we go and spray the specified area as per the WHO, and indiscriminate spraying also causes resistance. So we are very particular about it. And then the passive surveillance of the active surveillance of the contact people, including the wards of malaria and dengue are kept separately. And we do integratedly work towards malaria and also some part of the country filariasis. Thank you very much. I think I could emphasize on the monitoring part, surveillance part, which is accountability of the person, is the bottom line as far as I am concerned. Thank you.
Thank you so much, sir. And just to very quickly summarize, you talked about the two different verticals here, you know, the station health organization as well as the field areas where the Indian Army is posted and the different terrains where they serve, and how through appropriate monitoring, better accountability, creating awareness, they're actually managing it. But you still face the challenges are very similar, as you mentioned, that people are still going to the private sector, and there can be certain differences. But overall, as we see, there are three areas that came out from your deliberation. One is the accountability part. That is pupils and frontline health workers accountability. The second point was awareness part. You said that, you know, health, it is not that people are not health aware. They are health aware, or they can be made health aware, which we have seen during COVID. So the similar instance can be drawn in the other disease programs as well. And the third piece where the drug policy came, you know, in public sector, yes, India does have a drug policy, very strong malaria drug policy. The only issue related to that is that it is not communicated. When a doctor in the private sector is there, he or she doesn't even know that there is an existent drug policy. And there are different reasons behind that, because in our medical education system, often policies are not taught, only guidelines are taught. So we learn as doctors that how to treat a disease, but we don't learn as doctors that this is the policy, I have to, adhere to this particular policy at this certain point of time, and this policy may change, so we have to keep ourselves updated about the policies. And that kind of system is present in some medical colleges, in others they are not being taught. So with that, I would then come to a person who is very close to the communication side. We have Dikshit Neville Pinto, and Dikshit is from the science communication background. So Dikshit is pursuing his decade-long passion for science communication by curating content and leading the editorial operations at the Weather Channel India since 2018. Recently, he was instrumental in the launch of Sustainability Insider, a portal under Business Insider India that aims to be India's leading corporate sustainability media platform. So this actually comes from the intersection of communications, public as well as science. And with the challenges that we have seen, I would come to you with those specific questions, that how science communication and policy communication can be done at this point of time, especially science communication, because we know that the doctors are aware and updated about drugs, but they are not aware and updated about policy. So how we can achieve that? And at the same time, how we can make the people accountable with the mass communication formats.
Thank you so much, Kaushik, and thank you all the panelists for making time. Very timely conversation, and thank you, Malaria No More, for organizing this. Coming to the science communication part, the COVID-19 example was the best case study we could have in terms of how science communication is crucial in framing policies or reacting to a health crisis. And Malaria No More has been a case example for more than a century now. But COVID-19 showed us in real time how it can impact policies, how it can impact the response that we have at the grassroots levels. Hydroxychloroquine was one of the best examples we could have seen. The kind of miscommunications that happened in the initial phases, people picking up the preprint versions and publishing stories, detailed stories on that, which led to many people believing that something that can treat malaria can treat COVID-19 as well, and stocking up medicines and affecting the malaria response in return. So this kind of miscommunications is something that plagues media communications even today, despite being in an era where we are continuously fighting misinformation and continuously checking facts and instilling this notion among journalists to check each and every word that you publish. Still, we are facing these issues on a daily basis. So here's where we need to strengthen communication not from top-down approach, but from bottom-up approach, wherein we strengthen the regional reporters first, we strengthen the grassroots level health system first, and communicate what's essential. We are framing policies in metro cities and deliberating on them on our what is called niche audience. It's not reaching to the village level or the remote forest area where malaria is affecting most of the people. It's killing children in the areas where we are not able to reach as a policy maker niche audience. So it's important that we involve journalists at the grassroots level. We involve ASHA workers. We involve people who are directly in touch with these communities, who are helping these people understand what is malaria, what are all the symptoms, what you should be aware of. We should be able to reach out to them first and make them understand what should be the first response and how important it is to communicate these things to each and every, the last person, the mother who may not have come out of her house for years, to identify a symptom in her child's day-to-day activity. It's crucial that we reach to that stage and help them understand. Coming to the science, the role of science and innovation, in shaping a response to malaria or any health crisis in response. In general, I would like to take two examples here briefly. One is, of course, Malaria No More's case example from India, where they recently launched a couple of years ago, Malaria No More and weather company came together and launched mosquito index, and the communication that they took Odisha as a case example and tried to reach out to the grassroots level people and make them understand using the app, using your mobile phone. If you can track what's the seasons or what's the time of the year where you have to respond more, you have to take more precautions to mosquitoes or vectors. These are the kind of initiatives that can have a wide range of impact and can save lakhs of lives. If we can replicate similar models in remote parts of India as well as sub-Saharan Africa, where things are happening and most of the people are getting impacted. We have access to, especially India is fortunate that we have access to mobiles and data at a very cheap price, and even the remotest parts of India have been able to achieve this in the recent years. So communicating such indices, such responses, trying to make them aware of what is right, what's not, is very important. I remember when Martin was there in Times Tower, Malaria No More's CEO, he discussed with us briefly, and he was surprised that Weather Channel has a mosquito index to start with, and he was surprised why we are not aware, why grassroots level people who are working on the ground are not aware of such initiatives. And that's where business communication also should be a priority, where businesses around the world, if you're developing the technology which can help in poor people or vulnerable people in a way, you have to make an effort to reach out to those people first and try and make that technology useful to those people. Second example I would come to is the recent genetic modification research that has been going on. Most of this research is confined to global north, whereas the problem is in the global south. And a lot of responses are coming in, and the way we have to understand, especially the researchers in India need to understand that this should be a priority. When COVID-19 happened, many health researchers pivoted their research towards response to COVID-19, whereas malaria has been seen more as a everyday problem, and the response is not as rapid, especially scientifically. When we have solutions, there are promising results coming out of genetic modification solutions. There are many ethical and philosophical debates happening around these things. So intersectoral approach in addressing them, taking together city planners, health professionals, philosophers, anthropologists who are working with the different communities, taking media professionals, everyone into a table and discussing what's the right approach to move forward. This is the need of the hour, and this is the part which would be crucial in whether we will be successful in the end game or not. Thanks, Kaushik.
Thank you so much, Dixit. You brought many valuable points. First of all, accountability of media we have heard, but from you we heard that what accountability of media actually can be in terms of filtering and misinformation and taking care of that. We heard that there are barriers in reach of communication, so we need to basically move the needle at the last mile. We need to work with grassroots journalists or frontline journalists who are working on that front. You talked about risk communication, very similar one with a candid example of mosquito index. And you also talked about the gap that exists between global north and global south. I think in the last 5 years or so, it has been breached a lot. Unlike in the sub-Saharan Africa, in India, at least the decisions are locally very strong. And that is the reason that we have, more global South-based decisions, but still the funding and other sources that are decided in the global North, especially in terms of external funding from the different or major donors, that need to be really taken to this part of the world in terms of decision making. You talked about intersectoral influencers, which is really also very critical in terms of influencing or creating accountability in the different sectors. Now, time is short. I will come very quickly to Mr. Palani Loganathan. And I'm really elated to have him on this panel because he has seen the country from a very different perspective. He is the CEO of Audio Planet, so has the Music Symphony and has seen the country from that perspective. But he has also seen the country from the perspective of his association with Rotary. He is Vice President of Rotary Bangalore Midtown. And the first question, Mr. Palani, I would like to ask you is that we have heard about communication at a higher level. I would say this is above the line and through the line kind of communication. But we have also heard the challenges in terms of accountability of people and awareness of people. And here comes the roles of, entities such as Rotary, who are very close to people and who are very close to the ground in terms of delivery. So I would like to hear from your perspective that, what can actually be done in terms of raising mass awareness. Digitally, we have run programs of mass campaigns, but with the people, keeping in touch with the people with a local flavor, what can be done to increase people's accountability, but still not burdening the program per se with more human resources?
Thank you so much, Dr. Kaushik. And at the outset, let me thank Malaria No More and Economic Times for this wonderful initiative. And it's been quite a learning for me from the distinguished panelists that I heard. I have myself added on to whatever little knowledge I had about the parasite and the disease itself. Thank you so much for this opportunity. Yep, I'll come with a very brief and humble overview of Rotary as an organization in India, forget the world. We are a group of close to 2 lakh plus distinguished members, 4,500 clubs in India. I was privileged to know that Dr. Rajiv Tandon also is a distinguished Rotarian. And the Rotarians come from very, very diverse backgrounds. We have thought leaders, we have industry captains, we have people from varied professions, including the respected doctors, medical doctors community, to ex-army men being a part of our Rotary initiative, to the very important communication aspects that we spoke about, with media people being a part of us, as well as Rotarians. So I think Rotary is really, really positioned as a very good missing link between all these intersectoral approaches that is there to eradicate the disease and provide a seamless transition between the efforts of all the stakeholders at large. And one of the 7 focus areas of Rotary is disease prevention and treatment, and water sanitation and hygiene, I think, which is very, very crucial for this initiative of malaria eradication by 2030, and the clarion call given by our Honorable Prime Minister. Going forward, I touch upon what Dr. Swati shared in terms of screening not being there to even distinguish between the types of parasites, particularly the falciparum being so much more, capable of causing severe diseases and after effects. So this is where I would want to very humbly submit, and not to be mistaken for a proud thumping of chest of what my particular Rotary Club has been doing. And what I want to convey through the efforts of my Rotary Club is, what can 4,500 such clubs do if one club can do this, and how much we could work with all the stakeholders and the experts to kind of make this initiative a lot more successful and add tractions to each other's approaches. From the polio eradication drive that Rotary International has conducted, we know how effective Rotary's participation has been in polio eradication. And we were one of the founding partners of the global polio eradication drive, as you all may know. And we've been very, very successful in getting down polio to almost abysmal levels, or 99.99%, I would say. Anyway, so but coming back to my club and touching upon various panelists mentioning different areas of challenges that we face, screening being one of them, I would want to share a case study of how during the first wave of COVID, when COVID and Corona were the only thoughts on the mind of people, for the first 4 to 5 months, we lost track of a lot of senior citizens facing a lot of age-related ailments that they may have, diabetes and a lot of other things. Anything and everything in the medical sector seemed to be focused on Corona and COVID. And that is when our club alone took the lead along with many other Rotary clubs of Bangalore. And I'm proud to submit that in 6 weeks, we could have a screening of close to 40,000 senior citizens across Bangalore, in particularly under-challenged, underprivileged, and the shanty slum areas where they otherwise would not have had access to such screenings. And we could almost kind of give them a bit of OPD as well as or lead them to the right OPD centers after the screening. And that's 40,000 in 6 weeks is quite a significant number from one club with the help of obviously other associate clubs. And this is what we could do in terms of screening. And in terms of participation and collaboration with the various stakeholders that is required for the health initiatives of the country, we already have a classic example. We are for the last 20 years involved with mental health initiatives amongst the rural women and children in close to 206 villages with a program called the Manasi program, where we partner with John Hopkins University, where the founder of this program, Dr. Geeta Jayaraman, comes from, and with all our expertise in psychology and the help of another private health sector entity, St. John's Hospital in Bangalore, which is pretty well known. We are catering close to around 6 million population in the 206 villages and 8 districts, helping all the mentally challenged women and children to start with. And we are also kind of helping men too. But this has been a standard that the WHO is now recommending as the Manasi model to the developing nations of the African continent. If a program has to be that successful, it just talks about our ability to work with many other related stakeholders, including the public health entities and the ASHA workers too, in reaching these 6 million households. We also have 2 dispensaries, and between the 2 dispensaries, one of it is called HSIS, run by one of the foundations headed by our own club member, Prestige Foundation, which is a listed entity in India. We kind of take care of close to 10,000 patients a month with free medication and screening of the problems that they may have. And another organization, Gotigere Dispensary, where we do not so much numbers, but relatively closer numbers. And I want to use these as a very, very humble submission in trying to claim the effect that we could have by working along with the government and private sector organizations. In the Gotigere Dispensary, we are working with the municipality and the Karnataka government to kind of help all the patients get the relevant help that they require. And this is just a brief overview of where we could be the missing link between organizations who are all interested in the same cause. And getting to a little bit of out of the box thinking that was being spoken about by the panelists, I would want to try, or rather we as a club are trying the option of talking to experts like y'all and finding out whether we could set up biological traps for the most serious vector, that is your mosquitoes, in terms of having large maintained water tanks, where when I say large maintained water tanks, I'm trying to say instead of allowing the mosquitoes to lay their eggs and breed in areas where we have no control in stagnated waters, if we were to have controlled water bodies where we could have the natural predator, that is, let's say a fish like the Gambusia affinis, which is supposed to have very high affinity for mosquito larvae, or maybe our Indian native, the guppy fish. So if there are options like having these biological traps, it could be just aquariums in each of the balconies, or managed water tanks, small managed water tanks, not large, sorry, I mentioned large, small managed water tanks where these fishes could actually kind of eat away the larvae in substantial numbers. And we all know how much mosquitoes breed and develop exponentially in terms of each mosquito capable of 150 larvae at one time, and each of them again kind of going on to those exponential numbers. If we could use these ideas of setting up managed biological traps, we could definitely do a lot. We could also do a lot by using well-known repellents like the catnip oil or the citronella, though citronella not being as efficient as the well-known DEET repellents. But I'm just trying to say, if it could just add a little more momentum to one more bite being prevented, would it help us in the overall cause? We would want expert opinion on all these things as to how we could kind of manage these things and add a lot more traction. And last but not the least, we are a very connected organization with well-networked professionals. We will also have a lot of access to the CSR community, but we going as Rotary alone may not be as effective as partnering with organizations like Malaria No More to kind of go and give them a very good detailed blueprint where the CSR organizations also who are there for a cause can join hands with us and make the overall initiative gain a lot more momentum, gain a lot more traction, and achieve the end goal. And like Dr. Swati said, that the goalposts are different for the different sectors here. We could actually be that one entity who could share the goalpost of each of these different sectors and try to kind of make malaria not be there in the country by 2030. Thank you so much for the opportunity.
Thank you so much, Mr. Kulani, and that was really, very nice to hear. I was really expecting not a typical BCC focused answer, and I was expecting the vehicles that can be utilized to deliver at the grassroots, and you really talked about that. And at the same time, you touched upon a very important point, and probably larval source management is the one single area in malaria elimination where the program has seen the least number of innovations in the last 100 years. I had the privilege of referring one of the MIT awards at one point of time in IoT mosquito traps, and I know that the applications are so few globally in these types of innovation areas. I have 3 questions, and I know Dr. Kannan has to leave very quickly, and he is actually having conflicting meeting but sitting with us. And
Dr. Kaushik, sorry, if I can add one thing talking about larval management. If there is one country in the world which is mosquito free, and everybody knows it is Iceland, I believe there's only one mosquito in their Icelandic Institute of National History where that mosquito is kept to show people that there is a mosquito. And if that can happen because of nature's own larval management, because of 3 freezes in a year and 3 thaws in a year, where that kind of condition does not allow the larva to kind of propagate, we could do a lot more on larval management is my humble submission. Thank you.
True. I have response to that, but I'll do that. Before that, I'll come to Dr. Kannan with the specific comments that Dr. Ajay Gambhir has made. So he has said that, public health intervention, priorities, sustainable efforts, funding lacking, including on research like vaccine. Please comment on vaccine in India as we are not innovative and end up doing to job work. So, Dr. Kannan sir, you have talked about the health systems perspective, and very quickly, if you can respond to the vaccine aspect, this is a very nuanced area, and so many people are actually apprehensive on this aspect that why vaccine is not still not in India. So, could you please respond to that?
Sure, Dr. Kaushik. So one, before I answer, I'd like to really humbly appreciate each one of the speakers in the panel. I've especially appreciated Dr. Swati. And this is the first time I've heard somebody from the private sector with such great understanding and in-depth knowledge of the program. My response to Dr. Ajay Gambhir is a little dual. Definitely the issue around the malaria vaccine is still going through a phase where it has been launched in a very targeted approach in certain areas in Africa. Data is being collected. There would be a decision on its larger scale manufacture and use very soon. The opportunity that that same vaccine will be potentially useful in India is low, because the basic pathology, the pathophysiology, the vector are different as far as we are concerned. So that's number one. Number two, my response to, I think, his guarded optimism about public health strategy and innovation is a little influenced by what the country saw during COVID. And I personally feel that if we really pick up the learnings of what actually happened on day one when the country was informed of that particular virus transmission, to what happened in the first wave and then the second wave and the third wave. Innovations, vaccines, diagnostics, newer drugs, growing health systems, public-private partnership, political leadership, creating platforms for decision-making, timely resource mobilization and appropriate utilization has all happened. Today in our country, we hear about exact number of vaccinations that have been given, which has never been known in our country. We are aware that RDTs, PPEs, ventilators, oxygen supplies, all saw such a phenomenal change between the first wave and the second wave. There is a story to tell. Definitely, I loved the way Dr. Swati conveyed that this particular disease has been, for some reason, erased from the radar of everybody. And it has to be brought back. And it is organizations like Malaria No More, which is leading from the front. And it is potentially such like platforms with where media comes in as actually a fourth partner, where media actually talks of not only sensationalization, but actually partnering in a public health outcome, is willing to be looking at their own tenor, is willing to be monitored, is willing to be informed in the right way by potentially people who are suffering with malaria, rather than urban elite sitting down with just theoretical information. So I personally feel, one, Dr. Ajay, I feel the country has shown during COVID what are the potentials. It also showed during HIV what were the potentials. It showed during polio what were the potentials. So there are the stories. We eradicated yaws. We eradicated smallpox. There are lots of things that the country has been able to achieve, but at the same time, there are humongous challenges. The story of malaria is that we had actually reached almost elimination way back in the 60s. And we seem to have gone full circle. We seem to have reached a point where the challenges are now appearing to be unsurmountable. But I don't think they are unsurmountable. I definitely think when the country would take a decision, when people in the country would all join, we will see it happen. So I'll stop there. I do have to drop off. And Dr. Kaushik and Prateek ji, a very big thank you for having me here. Thank you very much.
Thank you so much, sir. It was a privilege to have you in this panel, and we really look forward to many more deliberations from you in near future. So we have also other questions. Another question from Dr. Ajay Gambhir, which I'll take first to respond that, yes, there are confirmation tests of malaria. Yes, there are first line as well as combination drugs available for malaria as per the national drug policy. And I'm telling you this from the background that we did an investment case research for about a couple of years or little more than that. back. And what we found is, in fact, anti-malarials are being used not only in malaria, but possibly in many other instances. So it is not that the country has any scarcity of these type of treatments. It's only what treatment should be used, what as first line, what as second line. And in terms of diagnostic, I agree that there are needs for ultra-sensitive or high-sensitive tests, because the current test misses a number of cases. There are subpattern malaria reported all across the country through the last decade. There are several reports, but nothing have been done on that front. I very strongly feel that we need to respond to this particular area very quickly and do something to do more sensitive testing at the grassroots, where the ASHAs are actually testing the people, so that we don't miss the cases. I would also take this question to Dr. Swati specifically, that, we are aware in public sector, it is very clear. It is either RDT, rapid diagnostic tests, or microscopy. And microscopy is happening in areas which are more accessible, more kind of urban setting, more infrastructure is available. But in majority of rural areas, especially the most marginalized areas, we have rapid diagnostic test, and they misses a bulk of the malaria simply because those cases are subpattern. So as physicians, as an internal medicine specialist, what do you recommend, or what do you people do in private sector to reliably diagnose malaria, and how you actually treat those patients, or detect the what we call is unconfirmed or unidentified acute febrile illnesses? So over to you, Dr. Swati.
Thank you. First of all, I'm humbled by the words of Dr. Tandon. So thank you. Thanks to him and the other panelists as well. See, definitely, I don't think the challenge lies in diagnosis, or the challenge lies in treatment of cases, or people are not aware as to what treatment policies should be followed. To a certain extent, yes. I think the problem lies in a mindset where we feel that limiting the disease is the only endpoint that we have, and it's not elimination of the disease. And also where we are not adherent to the national policies that are there. We try to, experiment our own ways. At times it is lack of awareness. At times it is, our own experiences with the patients and all. But the major problem is that we are not adhering to the national drug policies that are there. And if you look at the data now, then I think we have sufficient data to suggest that drug resistance and resistance to diagnostics is coming up now. If you see, SP has shown a lot of resistance in India now, and we had to switch. It became imperative to switch to different drug combinations. Lumefantrine came in, and we had to give away sulfadoxine for that matter, and pyrimethamine. Then again, if you look at it, then Plasmodium vivax chloroquine resistant cases, again, it might not be too distant for us, because Western Pacific region is already seeing this, and it might kind of come into India as well. And it would be a huge problem, because 50% of the burden that we see of Plasmodium cases in India are vivax. So if we get chloroquine resistance in Plasmodium vivax as well, then it would be a huge challenge, and we would have to look for newer options and different options, which again would become very difficult, because the major challenge is that this information is not percolated to the formal and the informal sector last mile as to what the treatment guidelines should be followed. We could kind of spell out the different treatment options that we have and everything. But what I feel right now is more important to actually, look at the bottlenecks that we have right now when it comes to the private sector. We definitely feel that, COVID threatened whatever advances, the age-old decade advances, the hard-won gains that we had against malaria. But if we look at what Dr. Tandon as well said right now, if we look at the successful containment of COVID and the world's largest national vaccination drive that we just conducted here in India, and we distill the learnings and the best practices and apply them to diseases like malaria, then I feel where already half of the battle, the ground has already been won, and we are moving towards the end decisive game, where we are about to formulate the national strategic plan for year 2022 to 2027. I think it is time we need to learn from these the different eradication programs, be it polio, be it COVID management, and apply them to diseases like malaria. I feel the first one that we actually, what COVID highlighted was the importance of timely, accurate geopolitical data that we had available during the COVID time, which we have been talking about, that is notifying the disease. But can we leverage the same real-time GPS-enabled Arogya Setu app or a similar app for, kind of populating the data about various malaria cases that are happening around us? Can each and everybody contribute to these online apps where we can, even a simple person can kind of say that, yes, I've noticed malaria in my community, or we are seeing an outbreak of malaria, of mosquitoes in our community, or we are seeing children getting infected, or the doctors or the private sector can, start populating this data so that we have neighborhood intervention strategies. We could have different health public policies around that. The other very important thing that I feel is, which Dikshit also mentioned out over here, was that we need to nurture a society movement. And with the kind of public messaging that we saw with COVID, with all kind of infodemics, complete bombardment, with the advisory ringtones to print media to door-to-door interactions and everything, can we come out with more catchy slogans like, I just framed one, COVID ke baad ab malaria ke paar. So, something like this, where we can bring in the I think the attention of the people and the different sectors towards malaria as well, because malaria has been forgotten, and we need to bring that leverage back. We need to bring that attention back onto malaria. So important thing is register and recall. And so can we do more targeted advocacy? Can we do more communication around this and, raise the need for elimination of malaria? The third thing, which, the second thing which we learned from COVID as well was, I would say that, again, investing into R&D, as was mentioned, and we were talking about the vaccine. See, if we look at COVID, then, timely, making of the vaccine and rolling out the entire campaign, I think was the last nail in the coffin, keeping my fingers crossed and being optimistic on that. But again, if we are investing more on R&D, if you're looking for more impactful tools, if you're looking at new generation antimalarials, if you're looking at the historical breakthrough vaccine that we recently had, can we improve on the vaccine? Can we have better vaccines? I think all this needs to come in as well to actually help us handle the elimination process better. And that is where I think we should work on. And also, again, coming back to the very pertinent thing and very important thing is, again, the drug resistance and the resistance to various diagnostics, where the government needs to percolate these drug treatment guidelines to the very last mile. And this is not going to happen overnight. You will have to kind of engage with organizations like IMA, the regional local bodies, and the various other bodies, where they have to, kind of work on this regularly, keep on percolating this as much as you can, disseminating this to the private sector, formal and informal, till the time the private sector realizes the fact that their responsibility is not just limited to limiting of disease. Their responsibility is towards the elimination of disease as well. So we need to move towards that. Then again, I think counterfeit antimalarials and the substandard antimalarials that are there in the market, that also needs to be looked at. This is a very important area which is being left out. So are we doing a pre-procurement kind of, look into the drugs that are being taken up? Because public sector, pre-procurement, I think quality check happens. But in the private sector, and especially the retail sector, these pre-quality checks are not done. And therefore, there are a lot of substandard drugs which are floating around, and this leads to a lot of drug resistance at the end of the day. So there has to be random checking by these drug regulatory bodies. There has to be pre-procurement checks, and also pharmacovigilance is very important now, because when we are using these anti-malarial drugs, how much of the side effect is being seen by the various sectors, and how can it propel us towards newer technologies, newer medicines? I think that is also very, very important to look at. So if you look at the private sector, I think we need to catalyze, convene, coordinate our efforts towards proper messaging, towards proper use of the drug policy guidelines that are there, also, notifying the disease, creating the data so that we can identify the hotspots, we can identify the pockets where mosquito breeding is rampant, or where, this leaking is happening, because we have a migratory population as well. And so, within the country and outside the country, the movement will happen. But how much can we track this data to actually contain the disease? Because COVID has proven that it is successful and we can do it. So I think we should really take in the learnings from the polio eradication, the COVID eradication, and apply that to the malarial disease as well, apart from what we already have. So as I said in the beginning, half of the battleground, I think even more than that, has been won already for malaria. It's only that we need to align different sectors now so that we can have a larger gain and we can reach our goal of 2030.
Thanks a lot. I will not take any more questions. Quickly respond to one question that came on genetically modified mosquitoes. Yes, there are genetically modified mosquitoes, more predominant in controlling dengue and still being tested now. There are a lot of ethical aspects or considerations to consider around that. We can't just kill all the mosquitoes in the world, because then human beings will be eradicated from the face of the world. So we need to just kill the vectors or reduce the vector population to a threshold where we can, live without the diseases that are being transmitted by vectors like Anopheles, Aedes, or mosquitoes like that. But then, there are so many harmless vector, mosquito population there. We just can't kill them because that will kill us. So before I hand it over to Prateek sir for the concluding remark, I would want to do a roundup with one area each, maybe very quickly, 1 minute. I would start with Dr. Sandeep Sinha, Brigadier. Sir, if you can move forward. Yeah. Over to you, sir.
Thank you. As emphasized, point was taken by one of the panelists that the goalposts, the goalposts which are faced by Indian Army and including Indian Navy, and I will like to add on here that the goalposts in India can be defined. Let's say Northeast, say Assam, say Rajasthan. And if you look at the whole prevalence of malaria and the incidences of malaria during the seasons, it is differently scattered at the industrial area. So the goalposts are fixed at the regional geographic regions. So here, I'd also like to emphasize that biological trap somebody talked about, and there is something called as sugar-trapped adulticides, which is being practiced in Africa, if I'm not mistaken. And they are putting some ventilations where the mosquitoes are attracted, and they are attracted because of the trap, and they die. However, the anti-larval and anti-mosquitoes will be maybe our target today. But tomorrow, say, we have got, as I said, 7.5 years now, since 2030. Our target should be stagnant water. Why, where, how? Elimination. This will be the bottom line. Thank you.
Thank you so much, sir. I would come to Mr. Palani, maybe in 1 or 2 lines, if you can say that what should be the focus going forward for public and community awareness aspect.
Yep. Our strength is footprint and the foot on the ground that we have. We would want to collaborate with every stakeholder, expert who can guide us, and we would want to kind of add traction and momentum to every stakeholder in eliminating the disease and the parasite. Thank you.
Thank you so much, sir. Dikshit, last point to you. Very quickly, maybe 1 minute, 2 pointers, what you would suggest to our audience as the takeaway message from the science policy communication perspective.
The responsibility now is with us in terms of how we adjust and make this popular, similar to COVID messaging. The health communication and science communication came to the forefront during 2020s. We have to make this again with malaria. And Malaria No More has been doing an excellent job with the Bite Light, Matlo Light, and these kind of campaigns that have a very catchy tagline, and many people are attracted to those kind of messaging. Last point, we have to approach this as a conquering the enemy from all sides. We need multiple methods, be it genetic modified, be it vaccine, be it the current successful approaches like ITNs and other things. We have to follow all these things together to achieve our end goal of elimination of malaria.
Thank you so much, Dikshit. So thank you, everyone. Every time I try to be part of these types of panels, I come to talk about malaria, and then I learn a lot about the health system, health perspective, ecosystem, and so on. And I feel enriched, and I go back. And then again, this cycle continues. But I feel with continuation of this cycle, we will be reaching a point where, we will be able to take or manage accountabilities as per the expectation in terms of malaria elimination. And I believe several points came. 1.5 hours cannot do justice to all the issues and all the innovations that are happening in this space. But yes, in terms of creating an overall awareness, I think we have a rich set of points. My colleagues will be communicating further in terms of how we need to take this forward, how we need to act together through our different campaigns in India. So thank you again, and I will hand it over to Mr. Prateek Kumar, Country Director, India of Malaria No More. Thank you so much. Thank you.
Thank you, Kaushik. That was absolutely wonderful, and I could sense a huge sense of purpose here with all the speakers here, and good to see some attendees still around, which is normally not the case when a session goes on for an hour and a half, and with such intense discussions. So these are very encouraging signs. Having said that, while Malaria No More has been on the forefront of addressing the issue of malaria, and all of us acknowledge that it's not getting the primacy that it deserves. The country needs to do much more, and thank you everyone for being candid about what all is not being done. Dr. Swati, I must mention that it's the first time a private sector panelist has actually come and been very transparent with what all the private sector is not doing. So it requires a lot of gumption. So thank you for that, and we'll take you on for that as well, because we need internal spokespersons to also lead the battle, because things don't change otherwise. Having said that, the country is also at a time when the Honorable Health Minister also has given us a slogan on what is called Malaria Mukt Bharat. And he's serious about it. He signed a pledge on the Malaria Day in April this year that obviously we were a part of. And we hope that catalyzes a journey for the entire country, wherein different stakeholders will come together and be a part of it. And unfortunately, by the very design of the program, so far the private sector was not even included. Now that's a real shame, because I think the entire conversation was focused on how a huge chunk, and I'm just looking at the formal private sector here. Dr. Tandon referred to the informal private sector, which I can tell you, and we all know, most of us all know, is even bigger. We work in these very far-flung areas called Koraput and Malkangiri, the districts in South Odisha. And we did what we call a private health provider landscape study. There were like districts out of districts where we couldn't even find 10 MBBS doctors, but there were more than 1,000 RMPs and quacks. And that's what the tribals have to rely on. So when we are looking at a spectrum when regular trained medical professionals may not be following the country guidelines, the drug guidelines and so on, what are we expecting from the other extreme there? So that's also, that's kind of the spectrum of challenges we're looking at. And yes, the sectors have to come together. The clarion call of Malaria Mukt Bharat is a huge force that can come, bring all diverse forces together. And institutions like Rotary, with such fantastic presence, Dikshit representing the media and the scientific community here. Again, I mean, the kind of voices that the amplification that these platforms can give is absolutely outstanding. And, we look up to that, because otherwise our voices are very, very shrill. Of course, we have the examples coming from army, which has a completely different regimen in terms of how malaria gets handled. It's literally the responsibility of the sepoy himself or herself to take care of her malaria situation, and every single foci is met with the attention that it deserves. The country definitely needs to go in that direction, and that's something that we all hope for, with lessons learned from the panelists that were speaking on the forum here. We definitely assume and hope that the same kind of political commitment and will that was demonstrated in COVID, actually even a part of it gets assigned for malaria. Let's be realistic that COVID also hijacked a lot of the other programs, and that's not a sustainable proposition. It was an extreme situation that demanded extreme action and reaction, and thankfully it is a wave that is probably now in abeyance for a bit, and hopefully for good. While that may not be the norm and should not be the norm, because then other programs suffer as well. But the country definitely needs a lot more attention on malaria. And that's why political will and international support, both these come together very closely. I've been a part of HIV programs before, and I've seen how international support makes or breaks how the country responds. A similar thing is happening on TB. We keep talking about polio, but let's be honest, a lot of it was driven by external support as well. And rightly so, because as a country with limited resources and means, we can only go up to a certain extent. Our health systems are already stretched. So we have to find ways to manage within the constraints that we live in. Having said that, there is a lot of hope. And with panelists like you supporting us, and let me end by thanking Economic Times, Platform Times Bridge, our partners, and my colleagues in Malaria No More for getting all of you here, getting this August audience to listen in for an hour and a half. I think these are good signs for the future, and together we will win against malaria. So inshallah, 2030, we will manage to get rid of the parasite. Thank you so much for your time.
Thank you.